Good afternoon. My name's Jay Bott. I'm an internist, a student at the Kennedy School studying Master's in Public Administration, and a Commonwealth Fund Minority Health Policy Fellow. Today I have the pleasure of introducing our distinguished guest, Dr. David Blumenthal. He's a graduate of Harvard College, Harvard Medical School, Harvard Kennedy School, and trained in internal medicine at the Massachusetts General Hospital. He currently serves as a Samuel Thiel Professor of Medicine and also serves as a Chief Health Information Officer for Partners Healthcare. From 2009 to 2011, he served as a National Coordinator for Health Information Technology at the Office of the National Coordinator in the administration of President Obama. In the federal government, he charted a course for the meaningful use of electronic health records while building important public-private partnerships to ensure successful implementation of the high-tech law. I was lucky enough to have crossed paths with Dr. Blumenthal in 2008 when we worked together to help mobilize doctors and medical students engage in the presidential election. In working with him, our team was struck by his humility, his grace, and commitment. He's been an incredible mentor and inspiration to many in the Harvard community, including his own son, Dan, who is training in internal medicine at the Massachusetts General Hospital, and truly represents effective leadership at many levels at both the public and private sector. In addition to a career in academic medicine, he served government as an aide to the late Senator Edward Kennedy, a hospital manager as senior vice president of the Brigham and Women's Hospital, and a presidential campaign advisor, and a public sector leader. Dr. Blumenthal is known as a terrific thinker, an innovator, and has been a key decision maker in the most important pay-for-performance program in American healthcare, and that's meaningful use. And that'll help usher medicine into a new area of performance and practice. Ladies and gentlemen, he also has an important place in our heart as a Commonwealth Fund Fellow because he's a co-founder of the fellowship and also has been a leader in high-performing health systems. Please give him a warm HSPH welcome, and I'll turn the seminar over to Dr. Blunt.
Jay, thank you very much. Just 1 second here. This is a continuation of a series whose sole purpose is to help you in the future when you assume some of the major roles in the United States or in the world to basically understand the kind of choices and decisions that you may have to make. David is absolutely terrific in experience in that he wrote a book about presidential decision making. He's been an advisor to almost all the senior leadership in health policy, and then he assumes a major role of great proportion in a presidency that just passed a major act. And what we've asked David to really talk about is what you think about when you actually assume that responsibility and you have to make decisions in a role which is very different than that as a university professor or as an advisor. David, it's terrific having you back in this role.
Thank you so much, Bob. Thanks, Jay, for that very kind introduction. It's great to be here. Great to see so many students here. I have, just from my perspective, before I start, I wonder if any of you have had the opportunity to serve in government or to serve in leadership roles. I know public health students often have those roles. Can you show your hands? It's great. So some of you will be able to perhaps identify personally with some of the things I'll be talking about. I'm just going to speak very briefly to kind of lay out the scene that confronted me when I got to Washington in April of 2009, and then some of the ways that I responded and a couple of lessons, and then we'll turn it open to your questions. So as Jay and Bob said, in April of 2009, I arrived in Washington having worked for a couple of years on the Obama for President campaign. And I arrived there as National Coordinator for Health Information Technology with the responsibility of implementing a new law called the HITECH Act. And that law set out a number of really formidable challenges. So one of them was that I and my colleagues in the Office of the National Coordinator was responsible for creating a nationwide, interoperable, private and secure electronic health information system in the United States. Now, that in itself, that vision of a pervasive, interoperable, private and secure system that could serve everyone all the time is a vision that's never been realized in the history of mankind. So it just doesn't exist anywhere on Earth. So right away, it was clear that we had expectations that ran way ahead of our technological ability. We also knew that the Congress had set aside up to $30 billion in incentives to reward hospitals, physicians, other health professionals who became meaningful users of electronic health records. So the method, one of the principal methods for us to get from where we were, which was a very low level of use and adoption of electronic health information systems in the United States at the time, to this image of an idealized system, we had this $30 billion in incentives as a major tool. We also had $2 billion in discretionary funds for my office in particular to help create the infrastructure. The incentive money was to be paid out to physicians and hospitals and other health professionals. So that was money that would go out the door into the pockets of people out there in the world. It wasn't money that we could control or direct, though we had to set the standards for meaningful use. But there was also this $2 billion to kind of lay the infrastructure, make it possible for people who wanted to adopt, professionals and institutions who wanted to adopt, to be able to do that. So big challenges, big on their own, just in terms of the scale, but we faced another challenge, and that was that the Congress had said that we had to produce a regulation by December 31st, 2009, that laid out the standards and implementation specifications and certification criteria for electronic health records that would support meaningful use. Now, if you don't know what standards and implementation specifications and certification criteria are, then we have something in common, because I didn't know when I got there what those things were either. But we knew we had to produce it by whatever it was. We had to produce a regulation describing it by December 31st. Now, I got there in April, so that's, you can do the math, that's 8 months. Take away about 4 or 5 months for internal review, because you don't just someday wake up and post a regulation in the Federal Register. It has to go through a very elaborate process of review within the administration, starting within the Department of Health and Human Services, and then going up through the Office of Management and Budget, and going through the White House, and then going out so it's a big deal. It takes months. So we really had about 5 months to produce this highly technical regulation. But there was a problem with that regulation, which was that it made no sense to write it till you knew what meaningful use was. Because the standards and the implementation specifications and the certification criteria laid out the technical basis for electronic health records to support meaningful use. Well, to support meaningful use, you had to know what meaningful use was. So basically, we had 5 months to define the meaningful use of electronic health records. Meaningful use was a concept that was new. The Congress left wide latitude to the Secretary to define it. And it was, I came to realize, a really fundamental concept, because information is the lifeblood of medicine. It is the most important resource that clinicians have in treating patients. If you don't know your patient's laboratory results, their past history, their medications, their problems, you are extremely limited in what you can do for them. So in effect, the meaningful use of electronic health records was could be translated into the meaningful use of information, because we were going to be defining what electronic records would be capable of doing in the way of providing information for caretakers of the American public. We were really defining the essential information platform for U.S. medicine. Big challenge conceptually, intellectually, a big challenge organizationally. So when I arrived in Washington, I arrived at to take charge of an organization of about 35 FTEs that had been created by executive order by President George W. Bush. It was a group of people who had never been tasked with spending money, never developed a grant program, never written a regulation. Their work had been advising the secretary on health information technology policy. They wrote contracts for studies. That was most of what they did. They did do some work developing standards on contract. So we needed not only a whole bunch of new regulations and conceptual work, we needed a new office, and we needed it fast because we had 5 months to do all this, regulation writing. The other thing I quickly came to realize, and I think this depended a lot on my understanding of how government worked. Here we were sitting with $30 billion, at least that's what the public thought. We had this money, we were just sitting on it, right? It was in our pockets, burning a hole in our pockets. There was no health reform at that point. This was part of the stimulus bill. This was the biggest thing in health care that the president had done at the beginning of his term. He talked about it a lot. He described it as a down payment on health reform. Well, if he couldn't manage this program, how could he be trusted to manage health reform? So there was a lot of attention. There was a lot of attention on this program and how fast it got out of the block. Did it look like we were in charge? Did it look like we were capable of implementing this very important new mandate? It wasn't just the public that was looking at this, it was my colleagues in government. People in the White House wanted to know whether we were up to the task. People in the Office of the Management and Budget wanted to know if we were up to the task. People in the Department of Health and Human Services, to the extent there were any, there weren't very many because no one had been confirmed by the Congress yet, wanted to know if we were up to the task. So we had to prove ourselves not only to our external audiences, but to our internal audiences as well. The last challenge, which I totally didn't anticipate, was a perceptual challenge. And that was, this was an issue that had been percolating for decades. The American healthcare system was known to be very deficient in its embrace of information technology, of modern communications in general. Only about 17% of US physicians had a basic electronic health record, only 15% of hospitals. It was the modal way of managing information in the United States was then, and frankly still is, paper. So we had been working, others had been working on this, and it had been a kind of neglected issue. The advocates for spreading health information technology were viewed as sort of white hat folks. You know, all these blue ribbon commissions had favored it. It looked like, you know, there was no downside to it. It was motherhood and apple pie. Well, as soon as the Congress put $30 billion into this, the press woke up. They said, where did this $30 billion come from? You know, who's going to gain from this? And pretty soon they figured out there was an industry out there that was going to gain from it, the health information technology industry. And pretty soon they started asking, who put the fix in? Who was responsible for getting this money passed to the Congress and set aside to fund this new industry? Well, it must be the industry, right? So the storyline was, and came back to me very quickly, that the Obama administration and the Obama campaign was in the pocket of the electronic health record industry. And there was actually I got a call one day from an investigative reporter at the Washington Post who had clearly already written his story, who basically was asking me to comment on the allegation that the electronic health record industry and certain specific individuals who were active in the Obama campaign had been responsible for inserting into the Obama campaign platform a commitment to the electronic health record and HIT cause, and then had lobbied through the Congress this set of provisions that were part of the stimulus law. And sure enough, above the fold, front page story in the Washington Post ran about how this was the case, implying that I personally somehow was linked to the electronic health record industry. So that set a completely different cast on. It turned out, by the way, not to be true. I had no involvement with electronic health records. I was on the board, I was on the staff of the New England Journal. My conflict of interest rules prohibited me even from taking honoraria, consulting. I had nothing, no involvements at all. The story went away, but it did alert me to the fact that there were stakes involved here that I hadn't anticipated, and that I would have to tread very, very carefully in my relationship with constituency groups in general and with industry in particular. Now, industry, of course, when you're trying to stimulate the spread of electronic health record and other technologies, their capability, their insight into what's possible is a very important set of data points. So that was an issue that I had to figure out how to manage. So what did we do in response to this? The first thing we had to do was figure out what our job was and understand that we couldn't do everything that was expected of us at once. And it occurred to me, and it seemed that both logically and from a perceptual standpoint, one of the most tangible and important results of our work would be actually to get the nation's physicians and hospitals and nurses to start putting information into digital form. That our ambitions to have a pervasive electronic system with information flowing everywhere couldn't begin until the information, the data about patients, was in bits and bytes. And that meant getting electronic health records adopted and meaningfully used. So we decided that initially the first step was going to focus on the meaningful use of electronic health records as the first step in a long set of steps that would get us, we hoped, to the vision that we were trying to accomplish. This meant that we could focus and had to focus our energy on meaningful use and its spread. The second thing that we then had to do was to figure out, okay, what had to change? What literally, in every physician's office, on every hospital nursing station, in every nurse practitioner's office, what literally had to happen in order to accomplish the meaningful use of electronic health records? Well, people who were reluctant, maybe fearful, technically not competent, had to be able to go out and choose a record and have it installed and turn it on and begin to use it and then begin to use it competently. They wouldn't be able, most care in the United States in the outpatient area is delivered in small physician practices. There was going to be no IT staff. There was going to be no hot and cold running help. Somehow the federal government had to make this possible. So the first thing we did was to concentrate on technical assistance and training. Training for a staff that could, IT professionals who could help physicians in small hospitals do this, and creation of an infrastructure that would make those trained people available so that those reluctant, concerned, technically less than totally competent people could actually do this. So we started something called the health, it was actually in the legislation that we had to do this, but we decided to make it our top priority to start a set of what in the law was called regional extension centers. And these were actually intended to be on the ground, local sources of assistance to physicians and hospitals. Now, I had $2 billion to spend on this, and I quickly realized that even if I spent all $2 billion on it, it wouldn't be enough. It wouldn't be enough to touch all the 550 or 600,000 health professionals who were eligible. We just didn't have that kind of an infrastructure to get into every town and every urban area in the country, to reach every hospital, to reach every physician group. Not enough money. So we had to set priorities. So one of the first things I did was to get the Secretary of Health and Human Services and then the White House to agree on who our priority populations would be. And we decided, after looking at several options, that we would try to help those who were least able to help themselves and those whose care might have the biggest impact. We focused on primary care physicians in small practices in underserved areas. And by June of 2009, I had, at a meeting at the White House, arranged for all the major players to agree that that would be our strategy. And that freed me up to set priorities within the office. The next thing I knew I had to do is I had to spend money. That may sound odd, but it's not easy to spend money in the federal government. There are lots of approvals you need. There are lots of safeguards you have to manage. And I decided that we needed, in order to make it clear that we were open for business and ready to go, that we had to make a major statement very fast about the programs we were setting up. The Regional Extension Center program, for example, the training program. Now, it is hard to spend money, and sometimes it's hard to get the attention of the people you need to get to approve the things you want to do. And though this seemed like a really important thing to me, there were lots of other things happening in the federal government. And I had to get this program through the approval process, up through the department, and through Office of Management and Budget, and through the White House. Well, I had learned something from a mentor by the name of Richard Neustadt, who was a professor of politics and government, one of the founders of the Kennedy School. And in my master's in public policy training, we had done a number of cases, and a number of them established the importance of deadlines. Basically, in government, nothing happens without a deadline. So part of my challenge was to create a deadline. And the way I created a deadline was by getting the people who were in charge of the stimulus bill, which this was part of, to single this program out as an important program and create a deadline for the announcement of this funding. Now, they were very anxious to do this because the stimulus bill was supposed to get implemented very fast. It was part of the response to the economy. Getting the stimulus money out the door was a high priority. So I had a contact in the Vice President's office. The Vice President was responsible for the stimulus bill's implementation. And I got an event on his calendar to announce the release of our funds. Once that was on his calendar, everyone had to line up to get the decision made in time for him to announce it. So in August of 2009 in Chicago, the Vice President announced the release of about $1.2 billion of our $2 billion, which was a way of saying to the world, the Office of the National Coordinator is open for business. And we're working, we've got this plan, and we're moving ahead, so don't worry. One last thing I want to say, since this is an academic environment. Over the course of many years in academia, I had written more grants than I ever want to talk about. And there's always a part of a grant up at the front where you're asked to write a conceptual framework, which is basically a model of the world. So how does the part of the world that you want to study, how do you think it behaves? What are the moving parts? How do they fit together? What are the relationships that cause things to happen? I didn't know how to imagine this huge change management project that I was setting out upon, along with my colleagues. I didn't know how to imagine it without some idea of how the world worked that I was trying to operate. So we actually did a model. Very basic, very primitive, some boxes and arrows, but it was good enough for us to kind of feel confident that we had a plan. And it worked wonders with my colleagues at the Office of Management and Budget, who felt like, well, these guys have thought about it. They're not just waving their hands, they've got a theory. So I guess I've taken more time than I wanted to, but I would say act fast when you have a new responsibility. Don't let the perfect be the enemy of the good. Sometimes something imperfect allows you time to do better down the line. Set deadlines and think analytically. Don't forget your academic training. It can be extremely valuable. And I'm going to stop there and let you guys ask some questions. We'd be delighted here.
Just one quick question for me, and then it goes to everyone else. In a short period of time, you had to recruit some key people. What went into your decision of who you would try to recruit? And also getting them in the government quickly is not an easy task either. So,
well, I knew that I needed two kinds of people. I needed people who knew a lot about IT and how to implement it. Now, I haven't told you my dirty little secret, which is that I knew very little about information technology when I got there. I really was not a technical person. I'd used an electronic health record, but I knew nothing about what was going on inside the box. So I needed someone who had real substantive knowledge, actually a couple of people. The other thing I needed was someone who knew how the federal government operated. So I got my boss, the deputy secretary. I reported to the secretary, but day in and day out, my interactions were mostly with the deputy secretary to agree that I would have two deputies. One, an operating person who would be from the federal government, and the other, a sort of policy person who would be more substantive. I also had the great good fortune that the chief information officer from Partners Health System, who I knew and trusted, had decided that he wanted to take 6 months and consult to the Office of the National Coordinator. So he was there with me as translator and technical guide. Then I began recruiting other people, but those were the two people I focused on first, and then they began recruiting folks. So once I had two deputies and one or two other people in place, special assistant, I felt like I could begin to focus on the policy and let them begin to focus on the recruitment of the people that they were going to report to them.
your questions now.
Hi, my name's Elna Nagasako, and I'm in the master's program in health policy and management.
Mm-hmm.
And so you'd alluded to the need to get buy-in, from different segments, including, people in small practices out, in various underserved areas. How were you able to do that, given, all of these other responsibilities and the high
Mm-hmm.
position you were in?
It's very important to see that when you're taking on a new program like this, you're in the change management business. You're not, it would have been easy to see this as a technology program, but it wasn't a technology program, it was a change management program. As I described what was required of clinicians to make this change, what we were really talking about is a psychological change. And I was fully aware that what we needed, was a change in psychology on the part of health professionals throughout the United States and on the part of the people who run healthcare institutions. So we quickly decided that we needed to have to communicate in lots of different ways and using lots of different forums. I began sending out emails to key audiences. We put together a list of constituencies, the usual professional groups and hospital groups and so on. And I would periodically send out emails. We set up a website, and we had a website, but we added to the website a regular set of messages, and I started blogging. as well. And then we had an attentive press that some of whom were quite technical and some of whom were not. But I welcomed the press attention and sought it in any way I could, trying, of course, to create a positive message. We had 2 advisory committees that had been set up by the Congress, which turned out to be a boon for us. One was a General Policy Advisory Committee, and the other was a Technical Advisory Committee. And we got those going very quickly and began holding meetings. I had worked on Capitol Hill, and in my work for Senator Ted Kennedy, I had seen the way in which he used hearings and open meetings as communications devices. So one of the things we did is we used the meetings of our advisory committees as places to surface issues that we thought the community needed to know about, and a way to get messages out. And what would happen is that these were open meetings. They had to be open by statute. They resulted in many blogs and stories that went out on through lots of mostly technical media on the issues that were in front of us. And so communication in every form that we could imagine it was the solution that we sought. And then when we actually finished the regulation and published it, I began traveling. We set up a list of groups we wanted to touch, and I would make a point of trying to get invited to speak to them. Sometimes I didn't have to work very hard. So I did, in the fall of 2009, I did a lot of traveling, speaking to groups and all over the country. When I was advised to do that, I thought, is this really going to be worth it? You know, it's a lot of work. I was commuting from Boston, so I would get on a plane every Monday morning at 6, and I would come home at 5:30 at night. And with travel, that meant I would get to Washington and get on another plane, and then come back. And sometimes I wouldn't come back to Washington the whole weekend. I'd fly back to Boston. It turned out to be a terrific thing to do, because it wasn't just the people I spoke to, but it was the kind of buzz that I was traveling out speaking to people. And it gave the impression that we cared about what people thought. And that's a powerful thing to communicate as a public official.
Other questions?
Hi, I'm Jeff Urim. I'm in the Master in Public Health program in Policy and Management. And my question to you is, I'm sure before you went to DC and while you were there at the ONC, there was a lot of challenges you were expecting, but what was the biggest challenge you didn't expect, and how did you deal with it?
There were 2 that I didn't expect. One was, I mentioned the investigative reporting discussion. It turned out that I was basically tracked by investigative reporters the entire time I was in Washington. I kind of felt sorry for some of them, because they would come to these incredibly boring events, you know, and I had trouble understanding it wasn't the kind of thing that their readers were going to care about. But there was one I felt kind of paternal toward. She was about my daughter's age, and I felt like I should take her out to lunch and say, you know, there's no Pulitzer in this for you. That was one I didn't anticipate the suspicion that would be directed at me. You know, we all think of ourselves as good people. It was, though I relished the chance to serve as I did when it was something that I had always wanted to do, it still was a sacrifice for my family and for me, to both physically and in many other ways, to do this. So the idea that you would at that time also be the focus of all this suspicion about your personal motives, and you know, you have to lay your life bare if you serve in the public. I disclosed all my financial holdings, all my family's financial holdings. My calendar was the subject of Freedom of Information Act requests, and so I knew that whoever I saw was going to be that I couldn't see anybody privately, basically. So that was one surprise, and it did change how I conducted myself. One of the reasons why, for the openness about the meetings we held, and I can talk about that later, was to dispel that suspicion. The other thing that surprised me was that though I expected to have close supervision from people in the White House and the Office of Management and Budget, I often found that when they got involved in my work, it was erratic and without real careful thought about what they were interested in. So the White House especially had very little interest in the substance of what I was doing. Some issue would get somebody's attention for some reason that wasn't clear, and they would suddenly descend on us, wanting more information. Half the time I could never figure out why. So I found that though the President's support of the initiative was very important and critical, the people around him were as often as not irritants as they were helpful.
With that, next question.
Hi, Dr. Blumenthal. Jim Kennedy. So I'm a Commonwealth Fund Health Policy Fellow, MPH student, and an emergency physician. And I have a little bit of a background in the military, and I worked at the VA a little bit. And what I'm curious is to what degree do you interface with or interact with the existing health records people in the VA and the military system? In the military, we could access people's health records worldwide. So I was just curious about that point.
We had a lot of interaction with the VA and the military, and a lot of very, I think, good sound coordination. We were developing the standards that would affect their electronic health systems as well as our own. And since the VA and the military actually are not insular, but they relate at many levels to the rest of our health system, a lot of people from the VA who get their care in the VA also get care in the private system, and a lot of the families of military people get care in the private sector, and some military personnel do as well. So the information that was present in the VA systems needed to be accessible outside it, and vice versa. So we worked with them closely in trying to make sure that as we developed the definition of meaningful use and the standards for electronic health systems, that they were aware of it and felt comfortable with it, and that it wasn't going to frustrate their plans. We also did some coordinated funding to try to develop pilots for information exchange between the VA and the DoD and the private sector. So we had, I think, a very positive, mutually supportive relationship, and it was a very important, an unanticipated and important part of the role that the national coordinator played.
Hi, thanks very much for coming and talking with us. I'll just stand to the side because it's so awkward. My name's Matt. I'm a MPH student, and I'm also studying to get my MD. I'm in the quantitative methods concentration. You have some clinical experience, clinical training, and also public policy training, and I'm curious how the two work together when you went to Washington, and in particular, how did your clinical experiences and your clinical training influence what you were doing in Washington? Thanks.
The identity that was most valuable to me in Washington, in the work that I did, the role that was most powerful was my lifelong role as a primary care physician. Wherever I spoke, I started out by describing myself as a primary care physician, as someone who had learned to use an electronic health record, somewhat reluctantly, because that's true, someone who was raised in the paper world and made the transition to the electronic world, and someone who saw patients and could understand how an electronic record could affect individual patients and individual clinical decisions. So that was something that I quickly came to realize was a role, an identity that would be extremely valuable to me. And it was valuable not just in a perceptual sense, but also in my attempts to imagine in a very personal way what we were requesting of physicians, what we were asking them to do, and how we could communicate to them, what fears we had to address, what reluctance we had to address, what technical obstacles we had to address. I don't think I could have felt that as clearly and intensely or had the conviction about what we needed to do if I hadn't had that experience. I'm not sure I would have had that same understanding if I'd been a lifelong user of electronic health record, or if I'd been your age and grown up in a world of electronic equipment. So those were incredibly valuable for me. The other thing that was valuable was 4 years that I spent in hospital management, because I also knew how hospital CFOs think. And I could imagine what was going on in the dialogue between the CEO, the CFO, the chief information officer, the chief medical information officer, and what would turn the tables on that dialogue in favor of an acquisition of an electronic health record. So I was much more benefited. I made much more use of my clinical identity. At the same time, my lifelong interest in public policy, the book I wrote about presidents, my service in campaigns, my work for Ted Kennedy, the understanding of communications and politics that came from that were also vital. So I don't think either would have been sufficient. Together, they made me feel like I had a fighting chance to get it right.
Thank you for speaking. My name is Andrew Che. I'm in the master's program in healthcare policy and management. You mentioned you had a lot of challenges that you didn't anticipate when you started your work. I was wondering, were there any leadership challenges or your approach to them that perhaps looking back in retrospect you may have wished you had done differently, perhaps, and would kind of convey that to us?
I sometimes feel like you should probably ask the people who worked with me and foremen about that. One of the biggest challenges I had was in transitioning an old office into a new one. And I inherited 35 people who had a particular set of roles and orientation. And I was asking them, we were required, it wasn't just me asking, we were required to launch a new program that by any standards was a huge new endeavor. And I had a lot of choices about who to replace and when. And the dilemma I had was we had to act quickly. We desperately needed capable help. I couldn't just wipe the slates clean and start de novo because it would take months before there would be anyone sitting in any of those offices. So I went through, and as anyone would, an elaborate dance of trying to keep some of the key people on board and find new roles for them. And I think in the process, there are probably some people who I kept longer than I should have, and didn't act decisively enough to kind of help them find a new place and make room for somebody new. So I would say that that was one management issue that was a constant source of tension and uncertainty for me. And any of you who have to change the culture of an organization, direct an organization in a radically new direction will face those kinds of choices. Who to replace, how soon, how long to wait before you decide someone won't be able to make that transition. And you can't anticipate always who will and who won't.
Hello, I'm Heather, a student from the School of Public Health, Master's in Health Policy and Management. I have a question regarding what you described earlier as the vision that ONC started with, or that you were originally tasked with as one large interoperable system for the country. Now that is your task at Partners, and I'm wondering what lessons you took from ONC and have brought to Partners in your short time.
Well, now my responsibility is to help Partners choose a new IT system for its future. It's a very different task in many ways than the one that we faced in Washington. That was a motivational task and a nationwide change management task. This is much more a matter of picking a system and then going through the task of actually getting it set up and running. It's fun for me in a way because it is so complementary to what I was doing before. So I'm getting a sense for what the on-the-ground challenges are when we try to do the things that we were asking of people. One of the things I took away from Washington was there are many things that have to be solved simultaneously when you're trying to do something like we were doing. And we had to get people to adopt electronic health records, but we also wanted to know that once they adopted them, that they would be capable of doing all the things that we hoped they would one day be capable of. One of the hardest things to get a big electronic system to do is something called interoperate, so that the systems talk to each other. And I don't think we did as good a job on that as we should have or could have, though I'm not sure exactly how we could have done better. But one of the things I'm very attentive to in this choice that we're making right now is to make sure that the system we pick is one that's capable of interoperability. That's not something you would necessarily prioritize if you were just picking a system for one place, because you kind of figure, if I can just get everyone who works in our organization, and our dispersed organizations to talk to each other, that's already a big deal. Much less getting them to be able to talk to people from other organizations or people outside the organization. But I know that the future is going to require that of us. It's actually already requiring it because of the unique market characteristics of Eastern Massachusetts. So I'd say one of the lessons I took away was an acute awareness of the difficulty and importance of interoperability and the need to be aware of the limitations of the technologies in that domain as we bring them aboard.
Hi, I'm Kevin Koo. I'm an MPH student in Society, Human Development, and Health. One of the interesting aspects of the HITACT Act is the rapidity of its implementation, which, as you mentioned, is most likely linked to its connection with the ARA Act, with the stimulus. And this might have necessitated on your part and your office's part decisions that had to be made without complete information, or certain events that you might have liked to pilot in series rather than in parallel, which as a result of the rapidity. I was wondering, looking back, if there are decisions that you made or things that you might have preferred to do over a longer period of time instead of the shorter term, which was required by the Act itself. Thank you.
In some ideal world, you would implement this in phases. You know, you would start with pilot projects, you know, in Boston and Omaha and, you know, San Antonio or something like that, and rural Wyoming, and then you would learn, and then you would change your policies in response to that learning. And you would also want the technology to be always to be better, more capable than it is. There was another factor driving this, which was as important as ARA and the stimulus funding, and that was health reform. The health reform legislation almost, not quite, but almost assumes that electronic health information technology is pervasive and available for use to contain costs and assure quality and make sure that care is accountable and all those other good things. So another reason for rapid implementation was to prepare for the delivery system reforms that were needed. The president called the HITECH Act a down payment on health reform, and it was in what would have been ideal in a way is to have the stimulus legislation, the HITECH Act, passed 2 years before health reform was implemented rather than 1 year. I understand all the limitations that the rapid implementation could cause and will cause. The fact that technologies won't be fully developed or as advanced as they might be 3 years from now or 5 years from now. That there will be people who will implement the technologies less than fully or less than ideally. But as a change management strategy, I think the rapidity was a positive. The deadlines were a positive. The kind of all-in effect was a positive. And what we did in effect, rather than implement gradually, is we implemented gradually, but not in a pilot way. We basically said we're going to do a regulation that has a stage 1 that's going to be pretty basic, and then we're going to come back and revisit it, and the technology will have progressed, and we'll set higher standards, and then we'll come back and revisit it again. So we outlined 3 stages of meaningful use. Hard to know, we're not sure. The verdict isn't in on meaningful use yet and on the HITECH Act. Trends are relatively positive. The proportion of U.S. physicians with an electronic health record has doubled since the law was passed. I believe that care improves with electronic health records. So to me, that's a good thing. My guess is that if we had delayed it, phased it, mitigated its impact, that A, providers wouldn't have responded as readily, and B, that the industry would not have responded with the capacity growth that it did and with the innovation that occurred.
Hi, thank you. My name is Angela Crane. I'm a physician, also a primary care physician, and I'm a MPH student in the Society of Human Development and Health. I'd like to ask you, in devising your strategy, change management, what kind of evaluative component did you add in terms of stage 1? What kind of metrics are you using to determine that you're ready to go to stage 2?
Mm-hmm. Well, we had this incredible luxury of $2 billion in more or less unallocated funds. So being an academic, I thought, we got to do some evaluation. So we actually let about $25–30 million in evaluation contracts. A lot of my friends did very well through those contracts, though I had nothing to do with allocating the funds. The difficulty you have with evaluations, as you know, is that programs take a while to be implemented. Then they have to be evaluated, and then the evaluations come in, and by then the program has already been redesigned. So we arranged for short-term and middle-term and long-term reports from those evaluations. We also arranged for a lot of data collection. So we augmented and we augmented existing surveys and started some new surveys that would give us insight into how people in the field were responding. And we identified some proprietary source of information, companies that were in e-prescribing business or companies that were routinely surveying physicians in their offices because they sold that data to some other vendor of something. And so we were able to set up authoritative annual surveys of the state of adoption and meaningful use, and then also to track on a more frequent basis the streams of data that were coming out of some of these other proprietary sources. So we had a long-term evaluation process, and we had these short-term data collection ideas. I actually had in the fantasy that we would get someone like Bob to go do spot polls, snap polls, once a month. I couldn't have talked to him about it because of my conflicts with Harvard. But the idea being that we'd want to know, almost on a month-by-month basis, what people were thinking, what they were doing, and how we should change our programs in response to that.
Hi, Monica Brown. I'm an internist and a MPH candidate in health policy and management and Commonwealth Fund Fellowship. I had a question. You alluded to the IT vendors and a little bit about the industry, and I wonder if you could talk about special interest groups and how you personally thought about that in terms of getting to your goal and how that would conflict. I'm specifically thinking about the obstacles that might come about with a true universal health record.
This agenda is so widely supported that it's not common for an organization to oppose it frontally. So the key organizations, the ones that really have influence in Washington, were at least formally supportive. And the American Hospital Association, the American Medical Association, the American College of Physicians, the American Nursing Association, you name it. If they were present and talking about this, they would always say, we believe in this, we support it, but we think you're going too fast. Or we don't like this particular part of the regulation, or we would prefer you spend your money this way. So at least there was a commonality of interest. My approach was twofold. First, to make a persuasive case that we were not asking too much, and to make sure that as in any way I could, and this is where I think my previous experience with Capitol Hill and with presidential campaigns and with an understanding of politics and learning from Bob how to think about politics was useful in terms of understanding what the breaking point was for some of these constituent groups and what their capability would be to undermine our agenda. And that mostly had to do with what they could do in Congress. And I could remember, as a former congressional staff person, what it feels like when someone comes in and tells you about something awful the executive branch is doing, and what you would expect to hear about that and what might cause you to think it was truly awful. So I wanted to make sure that in my ear, that story would never sound awful. And that actually turned out to be very helpful because we titrated our regulations against what we thought would be the threshold for Congress to step in. The American Hospital Association at one point took out full-page ads in the Washington Post criticizing our meaningful use regulation. And I had a sense of what we had to do to respond to that, to undercut their effort to get Congress to delay or postpone. So I would say that part of it is politics. The other part is communication, listening. I never turned down an invitation to meet with the AMA, the AHA, any other physician or professional group. I never turned it down. And I never sent subordinates. I always went personally, to the extent that my schedule could allow it. And that creates a sense of openness and willingness to listen. That is invaluable in terms of muting the anger that could otherwise arise in situations like that.
I'm going to thank David and just take one point of my own in closing. What David did just so beautifully was not only just lay out his vision, but you must have noticed he laid out the vision of everyone in the arena for what would happen. And that's where the experience really paid. Every inside government, outside, the media, interest group, how they would see this, and his ability to really lead here was based on his ability to think about their reactions while he was planning what he was going to do. This is incredibly insightful because most of us arrive with just some view of what we want to do, not how all these other parties will see this. So David, on behalf of the country, our students, thank you very much for doing this.